Welcome to Behind the Genes. In today's episode, we'll explore the research that shows how a low dose of aspirin can halve the risk of bowel cancer in people with Lynch syndrome. We'll hear about the real-life impact of living with the condition and look at how genomics can help shape a more preventative approach to care in the future. I'm Sharon Jones, and to help us unpack all of that, I'm joined by our guest, Dr. Katie Snape, Principal Clinician for Population Health at Genomics England, Sir John Byrne, Professor of Clinical Genetics at Newcastle University, and Drew Hyde, a participant in the Cancer Prevention Programme, which is also known as the CAP3 trial. So to start with the basics, Katie, can you walk us through what cancer is in simple terms?
Sure, Sharon. So our body is made up of cells. Those are the building blocks that make us as humans and other creatures and plants. And our cells need to keep dividing throughout our lifetime as our bodies are growing and working normally. And so we need to have processes in place in our body where our cells can divide, but then also stop dividing when we don't need them to carry on dividing. What happens in a cancer cell is basically that cell becomes abnormal and it doesn't follow the normal checks and balances and rules of cell division. So it starts to divide and grow uncontrollably, and it can start to invade other tissues. And obviously that can cause serious consequences.
We'll hear a lot more from Dr. Katie Snape in this episode. But before we move on, I just wanted to flag that there's an episode of our Genomics 101 Explainer series with Katie, dedicated to helping us get to grips with how genomics can help us understand and diagnose cancer. Do go and check that out. We'll put a link to that in the episode description. So the World Health Organization estimates between 30 to 50% of all cancers are preventable. So, Katie, when we talk about cancer being preventable, what does that actually mean? And what's an example of cancer prevention that people might already know?
Yeah, so some cancers are due to chance or just mistakes happening as our cells copy. Other cancers are because there has been damage to the genetic information within the cell that can be caused by certain things that can cause damage to DNA. So, for example, a sort of obvious answer would be skin cancer. Skin cancers can be caused by sunlight, the UV light in the sun, and particularly if we burn our skin or get sun damage to our skin, increases the chance of us developing a skin cancer. So you can think of lots of other examples, such as cigarette smoking and lung cancer. And so we know that there are a number of different risk factors that increase the chance of our cells developing damage and becoming abnormal cells and growing uncontrollably. So when we talk about prevention, we might think, well, could we reduce some of those risk factors and therefore reduce the chance of those cells getting damaged and becoming cancer cells? So I gave the example of skin cancer. We might put sun cream on if we're going out in the midday sun, for example. That reduces the damage of the UV light onto our skin cells. Or we might help people to go into a smoking prevention program, or other sort of risk factors, such as we know that being very overweight can increase the chance of cancer. We might help people get into more exercise regimes or improve people's diets. So those are the sorts of things that we might do sort of for environmental risk factors. But we also know, particularly in this context, that sometimes people are born, they carry genetic changes within their cells that they're born with, that are inherited, that run through families. And those can also increase the chance of some cancers developing. And for those people at higher genetic risk, then we might look to other ways that we might reduce that risk. We can't change the genetic changes in their cells, but we might be able to put things in place to reduce the risk for those individuals. And that might be medication, it might be surgery, or there could be other things that we might be able to offer.
Yeah, and with that in mind, is there anything more, that you can share about some of those risk factors that someone is more likely to develop cancer?
Yeah, so actually the biggest risk factor for developing cancer is age. The older we get, the more times our cells have divided, the more chance there is of a copying mistake that can cause that cell to become abnormal and start growing uncontrollably. And that's why cancer becomes more common the older we get. We obviously can't change our aging process. Then, as I've said, sometimes we're born with certain specific inherited factors that increase the risk. That might be one big high risk genetic factor, such as having a cancer gene that's important for that process of cell division that isn't working properly. Or it could be that we have multiple lower genetic risk factors that can kind of add up together to increase the risk. And those often interplay with some of those environmental factors that we've talked about, like smoking, for example, or weight, or alcohol, or other things like that. So most cancers are probably due to aging, and then there's a sort of interplay of genetic factors, but environmental factors as well.
That's really interesting to understand. And the focus of this podcast is sort of looking at kind of Lynch syndrome and what findings have come out around aspirin and having a low dose of aspirin. So I want to kind of explore what Lynch syndrome is and then bring in Drew to talk about his experience of having Lynch syndrome and how he got involved in the trials themselves. So from what I understand, Lynch syndrome is a genetic condition that can make some people more likely to have the chances of developing into bowel cancer. And Drew, this is your opportunity to sort of talk about what that's been like living with Lynch syndrome. And, I'd like to understand more about your story and how it came about that you discovered that you had Lynch syndrome, and to sort of share with our listeners your journey.
Yep. So in my case, I discovered I had the colon cancer before I discovered I was a Lynch syndrome carrier. Basically, at the age of 50, I noticed some change in my health. I was becoming a little bit more tired. My bowel movements had changed or whatever. So I went to the GP, and the GP basically said, well, you're probably too young for cancer, so let's look at other alternatives. And I had blood tests, and I had low iron, so I was on iron tablets for 3 months and whatever. Then eventually I went back, and finally the GP said, well, let's try a colonoscopy. And the colonoscopy revealed that I did actually have colon cancer. And then very quickly I had surgery, and then following that, I kind of asked the question, well, why me? I'm only 50, 51, why?
Yeah.
And basically I was told, well, it's probably genetics. And then I was referred to, St. George's and Katie, and I had the test and discovered that I was actually a Lynch syndrome carrier. And that's why, I'd got the colon cancer at the age of 50. So,
I mean, that's quite a journey. I mean, how did you feel? I mean, you already on one pathway and then having to kind of find out more. What was your experiences? What was the impact on your life? How did you feel?
I think I was lucky in that I had a very good surgeon. I had surgery very quickly, so that was the first hurdle. Then I had to go on to chemotherapy, and the chemotherapy obviously is far worse than any surgery or anything else that comes before or after. But having got through that, then I went through the St. George's onto the Lynch syndrome system. So the most important thing then really was to basically identify what that meant for me, but also, because it was an inherited characteristic, what it meant for my family. One thing that was interesting, and I say the GP was saying, well, you're too young to have cancer, is that there wasn't any history of cancer in my family, looking at older relatives. So, to be fair to the GP, that wasn't an obvious marker. So basically, yeah, it was, let's, find out what it means now going forward.
So can you sort of just take us back to when you were diagnosed with Lynch syndrome? What sort of guidance were you given at the time about managing your cancer risk?
Well, following the surgery, I was given various statistics which were fairly grim on, what your percentage survival rate were in 3 years, 5 years, 10 years based on the surgery, whatever. And that was kind of a bit harrowing. But, assuming I'd get through 5 years, I felt it was, my chances were quite good. As for myself, living with Lynch syndrome, that I was aware that having had the colon cancer, I then had increased risk of other cancers. So since then, I've been on a screening program, and I have colonoscopies or gastroscopies every year or 2 years. So that's been very good. So I believe now that if any other cancers were to appear, I would probably know very early on, because they would be detected through a screening process before they got to a point where they would be, maybe too difficult to resolve. So that's, I think the screening program has been very, very good. The main issue for me was what it meant for my family. So, being a genetic thing. So, very quickly, my children, who were teenagers at the time, were both tested. And they went through some counselling with Katie beforehand, about what it would mean for them to get a positive or negative result. Unfortunately, my daughter was tested as negative, but my son was tested as positive. So he's now on the same cancer screening program and has colonoscopies every 2 years. So, yeah. The mystery really, though, is where I inherited it from, because my
Mm.
father died when I was very young. My mother was in a care home at the time, and I wanted to get her tested. And at the time, her GP wouldn't test her on the basis that she was unable to give consent. But fortunately, I had power of attorney, and we could persuade him to, do the test. But she tested negative. So I'm assuming I inherited it from my father's side, but both my grandparents on that side of the family lived into their 90s without any apparent cancers. So it's still a bit of a mystery how I inherited it. But because what was important for me was to know which side of the family I'd inherited it from. Because obviously, with cousins and whatever on different sides of the family, I wanted to be able to tell them what the situation was. My brother also tested negative, which was a positive. So at the moment, it's just my son and I that have the gene, defective gene.
I'm sorry to hear that about your son, but does it?
Well, I mean, he has to go through a colonoscopy every couple of years, which, obviously is not a pleasant experience. But at
Yeah.
least at least he knows that, the first sign of any problem, the medics will be aware of it, and he'll be able to react.
Has it changed your kind of outlook on life, kind of having this window in possibly knowing stuff or not knowing stuff? How's that affected you and your son as well?
I think knowing is always a good thing, and obviously I wish I'd known earlier, and then, I could have taken more measures earlier on. So I think knowledge is definitely a good thing, and it would be great if more people could be tested or, could find out if they were carriers at an early age, I think.
Yeah, that's really important. And sort of moving into about the trial, more broadly, like scientists have known that there's been a link between cancer and aspirin for some time, with fewer cancers observed in people who take aspirin. So, coming to you, John, could you share a bit more about the history of inherited cancer research and how the focus of Lynch syndrome came about? Because this isn't new, is it?
No, absolutely, Sharon. And in fact, my story in this space begins 40 years ago when I was one of the geneticists who set out to try and find the genes that we've just been talking about. At that time, the group of patients who were the most obvious to begin with were young people with a condition called familial adenomatous polyposis, or FAP for short. And they get thousands of polyps in their bowel. And the only way to treat that was to actually remove the whole bowel when they reached adulthood, which was a fairly extreme intervention. And I was setting up a registry. We were trying to find the gene at that time, and we just found it, in fact, but we also were trying to find all the families. And I'd taken over responsibility for all the genetic services in the north of England, in northeastern Cumbria. And we started identifying families with FAP, and we went to visit one of those families, and this was the kind of light bulb moment for me, because I walked into the room and Mum had had her colon removed, and her son Jonathan had just had his first colonoscopy at the age of 12, and it was clear. And I was about to give them the good news, but as I walked in, I noticed that he had little bumps on his forehead called osteomas, little bony bumps. His mother had them just the same, and it was one of the features of this condition. So I knew he had the gene, even though he hadn't yet got the polyps.
Wow.
And it made me think, wouldn't it be nice if we could do something to sort of prevent these things happening rather than just waiting for an operation? And as it happened at the time, I was leading the English end of a big study, which you'll probably be aware of, where we were doing the vitamin study on women with spina bifida babies. And we were just about to identify folic acid as a way of preventing spina bifida in pregnant women. So I had these two thoughts in my head. Maybe we could set up a trial like this folic acid trial. And then one of my friends in Edinburgh said, have you seen this paper from Melbourne? Gabriel Kuhn had just done a big study looking at people with colon cancer, seen that people who took a lot of aspirin didn't seem to get as much bowel cancer in Melbourne as those who didn't. So that was the design set up. We were applying to Europe for a concerted action, so we had to think of an acronym that began with CA. So I came up with Concerted Action Polyp Prevention. But then in 1993, just as we started that trial, we were involved in finding the first of the genes for Lynch syndrome. We had a big family in Northumberland where there were lots of people like Drew's family, and there were 3 generations of cancer in the family. So CAP2 was immediately born in my head. In 1999, we had our first recruit, and we recruited until 2005. We found in total 1,000 people in 16 countries to join in. And we gave them 2 aspirins a day or 2 dummy tablets. 2 aspirins is quite a big dose, but back in my day, when I was a junior doctor, we used to give many more tablets of aspirin to people with arthritis, so 2 tablets wasn't such a big deal. Nowadays, it's seen as a very high dose. And it worked. Basically, to cut to the chase, when we looked in 2010, the people who were getting the aspirin were getting less bowel cancers. In fact, it was a 50% reduction. So the people who took 2 aspirins had half as many bowel cancers and fewer cancers of other types as well. We realised, although at this point immediately we saw that it was working, we knew we'd need to do another trial to see whether a smaller dose of aspirin would be just as effective. So CAP3 began, and the great news is that what we'll be reporting in the journals in the next few days when it gets published is that the people who were taking CAP3 aspirin in any dose were tracking exactly the same as the 600 milligram group in CAP2. So we're pretty sure that it works. We're pretty sure that the small dose is just as good. And the great news was that we had fewer side effects in that group. So in fact, no one had to go to hospital for a transfusion or anything, like that. Whereas in the 600 milligram group, we had a few people who needed treatment because, as you know, and everyone knows, if you take aspirin, there's a higher chance of having an ulcer that causes a bleed. And that was always the anxiety. But people like Drew were courageous enough to take the chance because they knew we needed to know the answer to this. And of course, when you compare it to the risk of getting cancer, taking an aspirin is a relatively small risk.
So what were your kind of considerations when you were designing the trial, having that knowledge?
Well, the first thing is it has to be fully informed consent, which means that you have to explain to people what that risk is. The important thing about aspirin is that doctors have a much worse opinion of it than it deserves, because if you work in a hospital, you'll often see people coming in who've had a bleed. It's not always caused by the aspirin. The thing is, if you come in with a bleed and you're on aspirin, everyone blames the aspirin.
Right.
About half of them would have happened anyway. In fact, the irritation of the stomach is much more of a problem in older people. So, in fact, the average age of the people in CAP2 and CAP3 was about 45, 46 when they started. Drew was a little bit older, but people in that sort of middle age group are much, much less likely to get into trouble than people in their 70s and 80s. And it's people also who've had a history of ulcers that have a bigger problem. We also knew that if you had a stomach infection called H. pylori, which is itself a risk factor for cancer, and about 1 in 6 people carry that bug. And we knew that if we fixed that with antibiotics, that would significantly reduce the risk of bleeding as well. So it was a manageable risk. It was something we could share with people. They knew they were taking a bit of a chance. But actually a good way of putting it in terms of the risk, for people in middle age, the risk of a low dose of aspirin is about the same as the risk of having a colonoscopy, which is very small, but it isn't completely without risk.
Yeah. And Drew, kind of like hearing this sort of incredible backstory about how we've got to these trials and where we are today, what was your experience like as a kind of participant of this trial?
I understood I was going to be on 100, 300 or 600, but wouldn't know for at least 3 years, or was it 5 years? I can't remember. And then sometime later in the post, we got these packs, and I remember at the time thinking it was like a rather dull advent calendar in that you'd have the days of the week with the little windows, and you'd pop the tablets out 3 times a day and take them. So I did that. I think, I don't think I ever missed a day or whatever. Initially, I thought I must be on a really low dose because I didn't actually notice any side effects. I remember saying to my wife, I said, I think I must be on the lowest dose because I don't see any side effects. It was a surprise years later when I was told actually I'd been taking 600. So
wow,
it was quite an easy experience, really.
We had a lot of problems. We had to pack the aspirin in 6-month packs because it was very expensive to pack this stuff up. We got the aspirin free from the Bayer company, but it cost us more than £1 million to actually put it in the packs for to satisfy the regulations. And a lot of people complained that the packs were a bit big and awkward, but that was just, a constraint. But it was not that big a deal once people got into it. But we did get a lot of complaints about the size of the packets, which couldn't do anything about that.
They came regularly through the post, and, so every 3 months or whatever, I got another supply and just carried on taking them. Yeah. So
what was going through your mind when you were kind of waiting for this potential outcome, Drew? Because like you say, it was a long time taking part. What was you, especially as you were opening your package of day, knowing exactly what you were going to get?
Well, I kind of knew it would be a long-term thing. I think I was committed
Mm.
for 5 years initially, but I carried on taking the aspirin for another probably 5 years after that. So, yeah, I was just sort of happy to take the aspirin and then sort of wait to see what the results would be. As I say, that I didn't really notice any side effects, so I wasn't really worried that it was having any detrimental effect on me. So I was curious to see what the results would be.
Yeah. John, the trial has provided like the evidence that, low dose aspirin can prevent bowel cancer. But are there any challenges that still exist with translating this research into clinic and ultimately patient care?
Well, yes, and I'm going to hand back to Katie, who's actually leading the charge on getting it into practice as well. But just to say that I'm actually now literally on my other computer finalising my bid to go back to Cancer Research UK because we want to go for 3 more years. We said that
Mm.
we would follow people for 10 years after they'd finished or after they'd started, so for at least 10 years. So the last person to join didn't finish until 2024. So we won't get to that person. It's Robin and one of my patients. We won't get to Robin's 10-year anniversary until 2029, by
Right,
which
yeah.
time obviously Drew will be even further on. But that will give us at least 10 years of follow-up because we know that there is this delayed effect. And that was seen right back at the beginning when people looked, for example, the nurses study in America where they followed 86,000 nurses and just asked them if they took aspirin. And nothing
Mm.
happened for 10 years, but those who were taking aspirin for more than 10 years saw a benefit. So in the general population, it probably takes that long to kick in.
Yeah,
And so we need to keep going for just a while longer. It's not as expensive now because we're not giving people aspirin anymore.
yeah.
But one of the reasons we made Drew's dose blind was because we wanted to know what the side effects would be when you didn't know how much you were getting. There's a danger if you're
Mm.
getting a higher dose, you're more likely to complain. And
Yeah.
actually, but it did work out that the people on the lowest dose had the fewest side effects, even slight side effects. The only thing we can't escape from is if you're taking aspirin, you get bruising more easily because it blocks the platelets, which are the little tiny blood cells which plug up little holes in your blood vessels when they leak. The good news is we now know that platelets turn out to be a major factor in triggering cancer. And so the aspirin, by blocking the platelets, is actually reducing the risk of cancer, but also reducing the risk of cancer spreading in the body. So this is new research, and we've got another big research project in collaboration with a team in Cambridge who are pursuing this. And then also the other exciting news is that my other partner, Ruth Langley, is running a big trial of people with cancer, and those who are given aspirin as part of their treatment have less likelihood of spreading cancer later on. So the aspirin is clearly
That's
doing
amazing.
something good at many levels in the system, surprisingly. And we think it partly because we used to have a lot of salicylate in our diet, which is what aspirin's made from. And we think that maybe we're putting back something that the body actually was used to having. But modern
Yeah.
diets don't contain any salicylate because of the way we prepare our food. So it may well be that a little bit of aspirin's a good thing for everybody. But obviously that's a choice that each person will have to make.
Yeah. I mean, it sounds like a real powerhouse of a drug, essentially, which you're finding out more about its benefits as research goes on. So, Casey, can you just give us a bit of a broad overview of Genomics England's new adults program, which is kind of looking at this sort of area of work and how can it benefit people?
Yeah, thank you, Sharon. So, the adults programme at Genomics England is being funded by government, and the government wrote about it in the 10-year NHS health plan and the life science sector plan to run a large scale genomics population study. So, looking at how we can obtain genetic information from people in the population and look at more proactive and preventative healthcare, and can we generate evidence on where, how, and why the NHS should start applying genomics into kind of more population health measures. So there's sort of two sides to this. So the first is thinking about pharmacogenomics, which is basically about how genetic factors influence how we respond to drugs. So lots of people have had experiences of having side effects from drugs. We've just been talking about that with aspirin, or for drugs not working so well for them. And we know that there are certain drugs that genetic factors can influence, whether you should take the drug at all, or if you do, what dose you should take, whether it's going to work for you or not, whether you might be more likely to get side effects or adverse reactions. So part of the programme is looking at that. And then the other half of the programme will be looking at sort of are the genetic factors relevant for sort of serious and high risk conditions in the adult population? So we could take bowel cancer as an example of that. It's a common condition, breast cancer, common cancers, or cardiovascular disease. And we
Yeah.
know that there are certain genetic factors for some people that have significantly increased their chance of developing those serious adult onset conditions. Can we find those people in the population and then put measures in place to prevent that? So, even just thinking about Drew's story, he didn't have a family history of cancer. The first time that he knew he had Lynch syndrome, he'd already developed bowel cancer. And we know that many people that have Lynch syndrome or other high risk cancer genes are unaware of their status in the population. And so
Mm.
the idea of this program is to really look at, well, if we were to look for some of these very high risk genes in the general population, could we then put measures in place to reduce the chance of them developing the serious condition as a consequence? So instead of Drew presenting with his bowel cancer, we'd actually already picked it up, despite the fact he didn't have a family history, and we'd offered him, let's say, aspirin if we'd known the information at the time, and we could maybe have
Yeah.
prevented him from developing bowel cancer. So, it's really exploring, looking at that a little bit more. Where can we get genetic information in the population? Where might there be a really well evidence, like, the work John's done over 40 years, this aspirin
Yeah.
about, is really well evidenced now.
Yeah.
Where are there
Yeah.
these opportunities for us to turn the dial on some of these common adult onset conditions?
What other challenges do you think with getting this out there do you see?
I think there's lots of challenges. I think it's a really complex program of work.
Yeah.
I mean, the first thing is that the risks might be different for people in a population that have a family history.
Mm.
So where I've worked for years, and John as well, in clinical genetics, we've seen the highest risk people, the people with lots and lots of cancer in their family, because they're the people that are
Yeah.
presented to healthcare services. So we've worked out the risks based on that population. It will be really different when we move to the population setting. We'll find fewer people, and the risks might be lower because there might be other factors that are giving them a lower risk. But that's not to say the risk is zero. It's probably still raised. So then what we need to do is we need to consider, okay, well, what can we do to intervene, taking into account this change of context from, people that we found through clinical services to people that we see in the population. And aspirin is a great example of this. So, if we find that someone has a Lynch syndrome gene, then taking aspirin, unless there's a really good reason for them not to take aspirin, is almost certainly going to be low cost to the NHS and really significantly reduce the chance of them developing bowel cancer with a low risk profile. So where are those opportunities? And that isn't clear cut. And that's why we need a large scale research programme that can try and help the NHS answer some of those questions, so it can decide how best to spend its money in the people that are most likely to benefit from it with the least amount of risk or harm to them.
Yeah, that makes sense. And so, going to you, Drew, what are your kind of thoughts on some of the challenges that Katie's highlighted? And is there anything else that you think needs to be improved in better supporting people living with inherited risk of cancer in the future?
Yeah, I mean, I think in the brief sort of 10, 15 years or whatever since I've been suffering, awareness has increased greatly. I mean, for example, my GP now knows about Lynch syndrome, whereas I don't think she did when I was first diagnosed. And I think there is a little bit more awareness out there, but I still think it's a lot less than there would be for, say, for breast cancer. So, for example, when a
Mm.
high-profile personality, reveals they've got breast cancer, you often get, information about inherited risks. You don't seem to get that with colon cancer, when it's announced that so-and-so, has died or is whatever. You don't get that same, it might be a genetic thing. I mean, when I was first told people that I had bowel cancer, the response I got usually was, "Oh, poor diet, was it?" And, I always felt a bit upset
Right,
that,
right.
actually my diet was fairly
Yeah,
healthy and, that was the assumption that people had. So I think anything that gets the message out there that, there is a risk, an inherited risk. I'm not sure what the statistics are now, Katie. Is it 1 in 400 people might be a Lynch syndrome carrier or something like that? It's relatively high for something that is, as we've said,
mm,
if you know in advance you're at risk, you can do something about it. But like me, I waited until it was too late
yeah,
because I didn't know, and then, had to have the surgery. So So anything that, promotes
Yeah.
the message that there is a risk. I know some people don't want to know about their genetic makeup. Obviously, that's a choice. But I think to give people, as many people as possible, the choice must be a good thing.
Yeah, absolutely. And I think one thing I've noticed through his thread is the sort of theme of funding and kind of what gets funding and that the amount of time it takes to kind of get that funding. Is there anything you wanted to add around the kind of funding model, around why some things get funded, more prominent, like Drew's kind of obviously talks about if someone high profile kind of comes forward and says XYZ, that kind of gets the spotlight shone on it, and there might be research going that direction compared to other cancers.
So maybe I could speak of that, Sharon. So partly because of my experience, I've now been made chairman of the grant committee at Cancer Research UK for prevention and population research. And there is a real drive to push more resource into prevention for the obvious reasons.
Yeah.
And also, it's got to be remembered, it's very difficult for the drug companies to fund this because it takes such a long time that the drug's out of its patent before they actually get to use it. So it's very
Right.
difficult from a business point of view to fund research into prevention. But they are keen to help us. But we really need sort of central government and the charities to focus on prevention if it's going to make a difference. And just on Drew's point on diet, I mean, diet is still important even if you have Lynch syndrome. In our CAP2 trial, the people who were overweight were more than double the risk of cancer. So it's not like an either or. If you've got a higher genetic risk and you have a bad diet, then that's, is going to contribute. But the other exciting thing is, of course, we now have medical ways of treating obesity in people. So one of the interesting areas is whether we should be, in the same ways we are for other high-risk populations with overweight, we should be giving overweight people with Lynch syndrome help to lose weight, because that will also reduce their risk. It's also worth just dropping in at the last moment here is that this is also a good news story in terms of treatment and further prevention. We now have a new class of drugs called the immune checkpoint inhibitors, which specifically target the types of cancer that Drew had and are much more effective in curing them. And also, we've just been given funding to do a project called Lynch, which I'll be helping with, but it's led by David Church in Oxford. And this is developing a vaccine against cancers in people with Lynch syndrome. The great news is it'll probably work alongside aspirin, because we know the aspirin is enhancing the immune response. So the two together may make this a curable condition.
So that's actually incredible. I mean, it gives so much hope for people. And I just wanted to find out if you had any more kind of reflections as we close, because we're going to come to the end of our podcast today. If there's anything more that you wanted to share, anything that has been missed, or anything that you want our listeners to know. And I think I'm going to come to you, Drew, first, because you're the person who's had to sort of live through this and go through this journey along the way.
I think just basically, if you're not sure, get tested. I mean, obviously there are financial constraints. I'm sure that running a DNA test is quite an expensive business, but I think if you've got any history of bowel cancer in the family, you've got any concerns about your health, speak to a GP and see if you can get tested as quickly as possible. And then, as I say, to get a better message out there that there are risks of inherited colon and other similar cancers. So.
Yeah, it's just getting that messaging out there for people to understand more and make those informed choices. And Katie.
I mean, I would say that the power of our, NHS and our academia and a healthcare system has been collaboration.
Yeah.
There's so many moving parts. There's commissioners, there's funding, there's the evidence, there's research, there's healthcare implementation. The UK is a really amazing place to work in genomic medicine. So, and I think that's partly because of the amazing collaborations that we have and the way that we can translate research into healthcare, as John's team have done with this amazing study. So let's all keep working together, please.
Absolutely. And John, I mean, it feels like this is your lifetime's work.
Well, yes, I'd become aspirin man. It wasn't intended. But Katie's done a fantastic work in her role as chair of the Cancer Genetics Group in the UK. So we've now implemented, we're the first in the world to really make this an absolute directive to the GPs and to all doctors to say people with Lynch syndrome need to be offered aspirin. And so that's a great step forward. But we also need to get it into the British National Formulary, and I'm working with their team so that the GPs are empowered to do this. It's actually part of their care package. But I would just say we've still got a long way to go. We've now got a national list of all the people with Lynch syndrome like Drew to make sure we offer them all colonoscopy. but there are only 14,000 people after several years of really pushing.
Right.
We think in the national population in all ages, it's about 1 in 300. That's a lot of people. That means there's about 150,000 people like Drew in the country, and we've only found 10% of them. So we can't just rely on family history for all the reasons Drew explained. Drew's dad probably died of Lynch syndrome, but we don't know because we've lost that record. So now we're checking every bowel cancer to see if it might be caused by Lynch. And that program is now kicking in, and we're picking up a lot more gene carriers as a result of that. But there's still a long way to go to get people aware of Lynch syndrome, to think of it when someone presents with a cancer, not just of the bowel, but in the womb, in the kidney, and other parts of the body. It's not just the bowel, but that's the most important group.
Yeah.
So there's still a long way to go.
Where you've come to now is still an incredible achievement, even though we've still got a long way to go, and I don't think we should ever lose sight of that. So we're going to wrap it up there. Thank you to our guests, Katie Snape, Professor Sir John Byrne and Drew Hyde for joining me today as we discuss cancer prevention. If you'd like to hear more like this, please subscribe to Behind the Genes on your favourite podcast app, and thank you for listening. I've been your host, Sharon Jones, and Behind the Genes is produced by Deanna Barak, Florence Cornish, Sophie McLaughlin and Dave Howard at Bespoken Media.